first. Okay. I would like to say mental health is completely neglected, as I said before. We are confronting important gaps, and our priority is to offer solutions. Mental health budgets are underfunded, and even if they, in countries where they have funds, are spending to going to psychiatric hospitals, and also the availability of psychotropic medication is limited. Who explain all of this in the report in 2022. And the mental health problems are more disability than any physical illnesses. Also, we have confronted everywhere the COVID pandemic, and this is an important emergency, millions of deaths, as you know, and with significant mental health implications. We are now recovering everywhere about the suffering of COVID pandemic. During the pandemic, mental health services were frequently disrupted and reducing access of care. And just at this moment, we recognize this disruption were mitigated in part, at least in part, by shifting services to online care. But the point is, before COVID-19, only a minority of people with mental health problems received treatment, and data show the pandemic has further expanded this gap in mental health treatment. And the patients are suffering a lot because of this. At least here in Spain and in Europe, we are confronting a high rate of suicide. People are really bad at this moment. I would like to remember the paper I have cited before, the Alan Catlin explaining help does not reach those in need, and the necessity to develop a new portfolio, new ways, different designing and applying different models of health delivery system. Okay, possible initiatives. We have a transdiagnostic perspective, that is the use of ICT. And here I am going to focus first in this transdiagnostic perspective, the case of emotional disorder. That is one of our apps. Why was it developed, and how was it developed, and how was it tested? It was a transdiagnostic app for the treatment of emotional disorders. The burden of emotional disorders is huge, and the global burden of disease show that depression and anxiety disorders both are among the top 25 causes of burden globally in 2019, before the pandemic. And this burden is high for many people across the lifespan, around the world. Doesn't matter if they are men or female or young, or doesn't matter the age, doesn't matter the culture, doesn't matter the situation of the country. Regarding emotional disorders, they are among the most prevalent mental disorders. Anxiety disorder, regarding the HKSAR study, are around the 28 or 29%, and mood disorders 20%. And also the comorbidity rates are very high, 40 or 80%, depending on studies. We know evidence-based psychological treatments are effective in the treatment of emotional disorder, we know, but the point is, the comorbidity has been looked, this comorbidity present in emotional disorder has been linked to greater severity, poorer quality of life, higher chronicity rates, and worse clinical course. That's a big problem. Evidence-based treatment have been developed for each emotional disorder, for instance, for panic disorder and agoraphobia, or social anxiety disorder, or generalized anxiety disorder, or any other disorder. And the point is, we have several manuals with separate handbooks, workbooks, on different protocols, and this may hamper the effort to achieve widespread dissemination of these evidence-based treatments. Fortunately, at the moment, we have not only this, but also we have recognized the efficacy of these treatments, of CBT treatments for anxiety and for depression. We have several randomized control trials explaining these treatments are useful. But again, problems, again, shortcomings. We need a protocol for each individual diagnosis, comorbid disorder or stressful symptoms and disorder not otherwise specified, nor are directly targeted, and high costs, the training and all these specificity in the different clinicians. We know we have important barriers. For instance, the lack of resources in public services, or heterogeneity of clinical presentations, or assessment of treatment of multiple mental disorder difficult. The training is not the same to assess a panic disorder or to assess an anxiety, a generalized anxiety disorder, or lack of regularity of sessions. We have to combine different protocols, or long waiting times to receive the treatment. In fact, some settings have, for instance, public specialized care have to face important barriers that hamper the appropriate delivery of this treatment. And fortunately, one line of research is the first line of research I would like underline is the transdiagnostic treatment. That means to apply the same underlying treatment principles across mental disorders without tailoring the protocol to a specific diagnosis. This is the definition by McManus in 2010. The point is, then we have one possible protocol, a transdiagnostic protocol to be applied to different psychological problems. Even that, evidence-based are still underutilized. As I said before, if we should train the clinician in every single protocol for every single diagnosis, could be really complicated. The conclusion is we have a necessity of well-qualified professionals. The result is 50% of people suffering from emotional disorder don't receive the appropriate treatment. And then we start to explain a theoretical model, central to the shared mechanisms approach is the theory of the triple vulnerability by Barlow. He speaks about a general biological vulnerability, such as neuroticism or extraversion, or behavioral inhibition, a general psychological vulnerability, a sense of uncontrollability and unpredictability, or a specific psychological vulnerability, a physical sensation about the world is dangerous, the future is dangerous, and he developed the unified protocol for confronting these main factors of vulnerability. It's a mechanistically transdiagnostic treatment for emotional disorder, was published in 2011. The principal goal is to teach the patients adaptive strategies to regulate their emotions. It includes 5 core treatment components and 8 modules. Components are present focus emotional awareness, cognitive flexibility, emotional avoidance, and awareness and tolerance of physical sensations and exposure. This one and other transdiagnostic treatments have shown they are effective. This efficacy has been shown in different meta-analyses comparing transdiagnostic treatments with control groups. Have shown the results show they are effective for anxiety, depression, and quality of life, and the effect size ranging between 0.68 to 0.84 for these measures. Additionally, the meta-analytic data shown the equivalence of transdiagnostic treatment and disorder-specific protocol for anxiety disorders. Then we have an important tool to confront emotional disorders. The other part of the term is the use of these protocols using the internet. If we use the internet, an important issue is the guidance. How much guidance needs the patient? The clinician or therapist guided versus unguided, completely self-applied, or just giving them phone calls, emails, chat, or video conference. And the guided ICBT or some evidence of equal efficacy. The point is, we have more dropouts in self-apply compared to face-to-face treatment, and the degree of contact by the clinician is related with the adherence and with the attrition of dropouts from this kind of treatment. For instance, we have an important tool, that is the transdiagnostic treatments, and we can combine this with the internet, but we have to take care of the guidance and the support made by the clinician. The best possibility is these blended treatments that combine the best of both worlds. Helen Ripper defines these blended treatments in this way: a standardized cognitive behavioral treatment protocol that combines traditional face-to-face care and distinct digital components to achieve maximum benefit for patients, therapists, and society. We are using this approach, blended treatments, saving time of the clinician and giving the best component offered by the treatment by the internet. However, as I said in my previous talk, all these approaches are mainly focused on the negative. All these transdiagnostic programs, the same as specific protocols, focus primarily on decreasing negative affect. And we were also interested in enhancing positive affect, that is, regulating positive affectivity. Positive affectivity is considered a core element of mental health, showing beneficial generalized effects on health and functioning. For instance, psychological strengths and significant activities linked to values, or behavioral activation strategies, or well-being therapy by FABA, or Frederickson, Broden, and Bill theory, that is, to take care and to enhance positive emotionality could be useful for the treatment of these emotional problems. The data suggest alteration in positive affectivity are observed in many disorders. for instance, low levels of positive affectivity predict the onset of depression, dampen positive emotions, are maladaptive, increase the severity of the problem, and high positive affect is associated with better health, both physical and psychological, and greater well-being. But despite the importance of disturbances in positive affectivity in emotional disorders, EU studies focus on promoting positive affect. As I said before, it has been explained, and we need techniques that include these characteristics: reach, scalability, affordability, convenience, expanding the settings, acceptability, flexibility, or use of non-professional workforce. And then we think the internet is an excellent tool to apply this, to overcome this gap, to offer the treatment to everyone who needs it, who need it, using the blended approach. Internet has important advantages: access to evidence-based treatment, even if people live in very rural areas, very far of big cities, reduction of stigma, waiting times are shorter, convenience, they are very well accepted by the patient, easier recruitment and data collection, reduction of the workload of clinician, and cost effectiveness. Important, really important advantages. Internet-based treatment have shown they are effective. With control group versus control group, they are effective, and the same as face-to-face, if we are confronted to face-to-face treatment, are effective. However, most of this evidence is limited to single diagnosing, and very few studies combine, and this is important for this talk, transdiagnostic plus apply on the internet. Most of the treatment, transdiagnostic treatment, have been applied face-to-face. Here we are explaining or applying this using the internet. Here we have our transdiagnostic perspective, including internet-based treatment, including positive affect regulation in an online transdiagnostic protocol for emotional disorders. Also, we have included some strategies coming from Marshall-Ineham acceptance for the treatment of the protocol of Marshall-Ineham, combined with the unified protocol by Barlow I just was speaking before. Here we have the first papers using our transdiagnostic approach to emotional disorder, using a blended format. Here you have in a community sample, the results in a community sample, but also we have applied this in a national health system in Spain with good results. And I don't have many time to go into the specific objectives, but we were interested in knowing if this could be effective for depressive and anxious symptomatology, as well as positive and negative affect. If we could find a differential effect of a specific component to address positive affect, or what could be the role of positive affect, and to know if this could be acceptable for the patients. Okay, it was a randomized control trial. We have 3 arms, the block randomization, 3 conditions, a waiting list condition, a transdiagnostic internet-based protocol, including positive affect, or the transdiagnostic internet-based protocol without positive affect. The trial was registered. The trial received the ethics committee of our university, Universitat Jaume I. The trial was conducted in compliance with the study protocol previously published, following the consort statement and the consort e-health guidelines, spirit guidelines, and as I said, we published the study protocol. Okay. We calculating an adequate sample size following the data on the literature. And here is the study population: major depression, dysthymic disorder, obsessive compulsive disorder, because it was designed before DSM-5, panic disorder, agoraphobia, generalized anxiety disorder, social anxiety disorder, and not otherwise specified disorder. The inclusion criteria was meeting DSM-4 diagnostic, ability to understand and read Spanish because the text was in the Spanish, access to internet at home and to have an email address, and providing informed consent. Exclusion: suffering from severe mental disorder, moderate or high risk of suicide, medical disease condition that prevents the participation for carrying out the treatment, receiving another psychological treatment during this study, or increase the change or medication. This is the flow chart. We collected more than 500 people was interested. Finally, 402 performed the initial interview, and some were excluded because different exclusion criteria. Finally, 216 were randomized, and we through the whole study, and we analyzed following the intent to treat strategy. I am not many times explaining the characteristics. The educational level was quite high. Gender, mainly women. Marital status, single. And the age was between 18 and 62. The principal diagnosis was generalized anxiety disorder, or social anxiety disorder, or depression. A lot comorbid, and as I said before, our protocol, we say that transdiagnostic intervention, mainly based on the unified protocol and some components of the emotion regulation script from DBT, Marshall-Linehan protocol for DBT, present focus, emotional awareness and acceptance, cognitive flexibility, emotional avoidance and emotion driving behavior, interoceptive and situational exposure, plus psychoeducation, motivation for change, relapse prevention, plus a component of positive affect regulation. Here you have all the modules, the treatment modules. 11 components are focused, traditionally focused, the negative, and also the same, relapse prevention, and 4 are focused on positive affect components. We are really interested in promoting this. And the content of the modules, we have the first one is emotional disorder and emotion regulation, psychoeducation. The second one is motivation for change, is to enhance motivation for change, showing that attitudes toward change, and explaining to the patient that the motivation fluctuates, general set and specific goals through the treatment. The third one is understanding the role of emotions. It's about the nature and function of emotion, the positive and the negative, and it is explained the 3-component model of emotions. 4 is accepting the experience emotionals. This is more focused on DBT by Marshall-Linehan strategies. Acceptance, we think, is crucial. the acceptance, the experience emotional, practicing the acceptance and learning to accept, and taking perspective and practicing cognitive ability, explaining the importance of emotional avoidance in the maintenance of disorder, and also the concept of emotional driven direct behavior. Also take very the strategies from the Marshall-Linehan strategy, that is, don't to do just this emotional driven behavior. You have to stop and think about accepting and coping with physical sensations, and daring is important, daring, facing emotion in the situation in which they occur, situations, for instance, to exposure to emotions, to patients learn to how to build hierarchies, both in vivo and in imagination, and they are explaining the importance to tolerate the emotions and reducing the behaviors, avoidance behaviors. Relapse prevention, this is the final module of the traditional treatment. All aspects of the treatment are reviewed in order to provide ongoing treatment and to aim to ensure the improvement is maintained in the long term. But as I say, we are not only interested in this, we are interested in this, focus on positive component, and for this reason we added 4 modules. First is learning to enjoy, to know the importance of positive emotion in evolution and the importance of this emotion for broadening our intellectual, physical, and social resources, and to teach procedure to generate positive experience. Our mood induction procedures promote involving in pleasant and significant activities, and having contact with others to learn how to enjoy positive experience and favoring positive aspects in life, the small things in order to enhance well-being, to know the importance of smile and its positive consequences, learning to live, to learn the difference between positive experience and to achieve psychological well-being, that is not only hedonic perspective, but eudaimonic perspective, to understand the importance of identifying the individual's own psychological strengths and carrying out meaningful activities linked to values and goals in life, to understand the concept of flow and the importance of performing activities in this way, and to start to live a meaningful and valuable life. The third one is, okay, you have learned all of this, now start to enjoy, to know the importance of positive emotion in evolution, and to teach procedure to generate a positive experience. No, excuse me, this is the, okay. Then with all of this, we initially manualized a protocol. We developed this protocol, and was very structured. A protocol, a manual protocol for the patient, and a manual protocol for the therapist. Here's one. And then later, this protocol was adapted to a multimedia web platform to be completely self-applied via the internet. Here you have the Psicología y Tecnología in Spanish. This is the address of our platform. Here you have some examples of the adaptation to web. For instance, the module 4, accepting emotional experiences. You have, this is the appearance. It includes, as you can see, text and videos, and it's very, very easy to go through. That is to advance or to go to previous page. This module, for instance, has 4 objectives: to understand what acceptance of emotional experience consists of, and it's important for the treatment; to understand the concept of non-judgment awareness; to learn to see emotional experiences from the point of view of an outside observer; to learn techniques for training in awareness and acceptance of experience; to learn to observe experiences as they arise without judgment. What does it mean, for instance, explain, what does it mean for them to accept emotional experiences? Because sometimes they are afraid. If I accept, okay, my life is going to finish. No. How to achieve, we teach them it is important to focus on the present moment, to be open to the experience and the facts, radical, very radical, as Marshall in defense, non-valorizing, acceptance of experience, choice of experiences, and without trying to control, just to accept. They are here, this experience, okay. Actively choose experiences and do not seek control them directly. The aim is to accept the experience. For instance, we explain, okay, observe the emotional reaction in the present moment, in the here and now, as opposed to living in the future or in what could have been. That experiences are accepted and lived in their own condition without avoiding them or trying to control them. Ability to stop the cycle of interaction between thoughts, physical sensations and feelings and behaviors in order to observe the experience, the point is, more objectively. And developing this skill, that means awareness, and this can help to achieve greater emotional regulation. The fact is to build an open attitude toward situation. We explain to the patient this means a way of being in the world without prejudice. And we use different techniques. What techniques, for instance, what they refer to what I have to do when I do the awareness raising, just observe, describe, participate. How to techniques. They refer to how I have to do it. Do not judge. Do things one at a time and act effectively. And also the modules include exercises, very different exercises to practice in each module. And also each module includes self-check questions in order to be sure the patient has understood the meaning and the message in each part of the module. Also, the program can do some important issues, some important aspect that it is not possible to do in the face-to-face treatment, traditional treatment. The duration of the program can vary among users, and participants in both treatment have access to the protocol for a maximum period of 18 weeks, but they can go before or after and to read and conduct again the different exercises. Also, the app includes a home, a home explaining what is the treatment, a calendar explaining in which part of the protocol are you at this moment, review, I can read again, do again, and how am I? Because after each module, the system asks several questions, presents some assessment protocols, the patient can see their evolutions during all the program. Then the program includes an assessment protocol, also support. I explained before was a blended protocol, weekly messages and emails from the therapist. They are completely self-sent. weekly messages. And also, if a patient fails to go into the program during some days, they receive a motivation message. Also, homework tasks, and also multiple choice questions. And this is ICT support, completely automatized. And also we use, because it's blended, human support, weekly phone calls, maximum 5 minutes. That is, we are able to use a minimum time of the therapies. Here you have the outcome measures, the fundamental outcome measures, the mini for the diagnostic, the primary outcomes, anxiety, depression, and positive and negative affect, and some specific measures for the different symptoms of each disorder, personality measure, and quality of life. And also we were really interested in expectation about the treatment and opinion of treatment. And the results, we follow an intent to treatment, and we also calculated effect size, and we also calculated clinical significant change. But this randomized control trial has been published. I am not so interested in explaining these details, where the demographic characteristics before and the clinical characteristics before, no problem regarding statistical point of view. Just to say, the BDA diminish, and there were differences between the treatment versus waiting list, a significant decrease in depression, and significant interaction effects. The same can be said regarding anxiety, a significant decrease, and not observed in the waiting list control, and significant interaction effects also. And regarding the positive affect and negative affect, positive affect the same, it was increased, and no in the waiting list, and the negative, PANAS negative, the same. The results were really good. Here you can see graphically these results in both conditions were in the right direction, and the waiting list was not observed the change. And the same regarding neuroticism and extraversion, was simply because we would like to know to improve the vulnerability of this person. So quality of life, significant increase, and significant interaction effects. Here you can see the graphically, and time. We try to also to assess the difference in diagnostic specific measure, but we didn't have enough statistical power, because it was different, the number of patients suffering the different disorders. Okay, the effect size were really good. We were happy with our effect size. For instance, in the positive, the condition that includes the positive was really good. And okay, and effect size regarding were less important regarding personality, or for instance, in quality of life, really good. Again, we should underline these good results. And also, I would like to say also regarding the expectation and satisfaction with the program for the participants, where before were really high, and the satisfaction later on was even higher. So patients after or before, the expectation was good in a scale 0 to 10, and later on even higher. So we can be satisfied with these results. It seems a transdiagnostic treatment applied by the internet is well received, is effective, and is well received by the participants. The results were also clinically significant from a clinical point of view, not only from a statistical point of view. Regarding the main results, the BDI, BI, and the PANAS, okay? And we have a dropout rate high, and in line with this, it is expected in the literature, because this is an important problem. We need to improve the dropout rates, and this depends on the clinician support. Discussion. Finally, I would like to underline that both self-applied protocol modalities led to a significant greater reduction in depressive and anxious symptomatology, and significant decreases in negative affect and increases in positive affect. And the participants who received the treatment score better at post-treatment compared to the waiting list group. And results show a statistically significant change from pre to post. For this, we can affirm the protocol, the transdiagnostic protocol. Our protocol is named transversal protocol, is effective. And also, were quite small effect size between the two interventions, but the effects were not significant. Where the effects were consistently larger in the condition that include positive affect. In this condition, we find a higher percentage of reliable recovery and lower deterioration rate. Regarding acceptability, as I said, both protocols were very well accepted. And significant differences were found between both conditions before and after the treatment in favor of the condition that includes positive affect, was better accepted, a better rate, and the clinical meaningful improvement were found in both conditions, Okay. Finally, the conclusion was the online transdiagnostic treatment demonstrated significant improvement compared to waiting list and all primary and secondary outcomes with moderate effect size. The condition with a specific component to upregulate positive affect reveal larger treatment effects on measure of positive affect and quality of life compared to the waiting list condition and to the traditional treatment condition. The online intervention was very well accepted with high scores on both expectation and satisfaction. However, even we have these good results, because this is the first randomized control trial intervention with a specific component to upregulate positive affectivity, and the findings indicate that emotional disorders can be effectively treated with a transdiagnostic intervention via the internet. And regarding the inclusion of positive affect measure, we found positive emotion play a fundamental role. And this study included a large sample of people from a community sample. And the internet-based format of this transdiagnostic protocol facilitate the availability administration of the program. However, we have quite high dropout rates. Then we have to take into account this problem and improve. Improve. There are different ways of understand dropout rates, but doesn't matter. We have to find a way to diminish these rates. Okay. But we also have limitations, no? There was not enough statistical power to detect significant differences between the two intervention groups of positive affect measures, different number of modules in the two protocols, and the follow-ups were not included in this study. Now we are analyzing the follow-ups results. In conclusion, we have developed a transdiagnostic internet-based psychological treatment protocol for emotional disorder. I would like to remember emotional disorders are the most prevalent disorders everywhere in the world. And we have included a specific component to upregulate positive affect. And this protocol has shown able to improve the clinical situation of participants. And future line of research, we are at the moment dismantling designs in order to determine which are the active components of the protocol. All the modules are needed, or we can skip some of them to test different blended formats, how much support the patient needs in order to reduce the dropout rate, or to test other existing techniques and strategies to improve positive affect. Future research for improving dropout rate, we can consider other ways of reducing this. We are working on this aspect because it's one of the key issues in internet-based protocols. Also, it is essential to disseminate and implement this protocol in current care, because usually the results stay at the university or the research center and don't go to the routine clinical care, and digital interventions should go into the mental health system. Psychological treatment can be applied everywhere in the world, and this is an important barrier we have to overcome. And also we have to test other possible positive strategies, positive psychology strategies, for instance, well-being therapy strategies, behavioral activation strategies, other possible strategies to develop other. We have the data about the importance of positive illusion, or the positive flexibility, psychological flexibility, or pragmatic prospection, openness to the future. We have to think about how to mix all these strategies inside a clinical protocol to apply them and to improve the actual or current psychological treatment. We are doing this. For instance, this is a protocol for dismantling a study for depressive symptoms. At the moment, this is the protocol, and we are testing this. At the moment, is Adriana Mira in charge of doing that. Or we are also testing the efficacy of a blended and low intensity internet delivery. In this case is Alicia Monreal and Noelia. They are in charge of this. This is the protocol. And the key and important point is we need to train professionals. We need to be in contact with other professionals from different disciplines. In order to conduct this, we need experts in artificial intelligence, we need experts in data analysis, we need experts in art, in video, in graphics. We need a lot of experience in order to improve, and also we need a very important training in clinician in order to understand this treatment. Another question we are also thinking about and trying to improve is the therapeutic relationship. We think as ever, like ICT-based applications are as effective as traditional therapy. And this can support the therapeutic relationships. The point is we have to train, we have to design, we have to develop this ICT digital therapeutic for improving and for facilitating and enhance the therapeutic relationship in the clinic, because mental health in a digital world is coming, and we should be prepared to confront these challenges. Many thanks.